Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
A bone marrow transplant, also known as a stem cell transplant, is a procedure that transplants healthy blood stem cells into the body to replace damaged or diseased bone marrow. And the cells can come from your own body, they can come from a donor, or they can come from umbilical cord blood.
Stem cell transplants are often used to treat cancers, most often cancers of the blood or immune system. Those examples would include leukemia, lymphoma, and multiple myeloma. Joining us in studio to tell us more is the director of the bone marrow transplant program at Mayo Clinic, hematologist, that's blood specialist, Dr. William Hogan. Welcome to the program, Dr. Hogan.
Thank you very much for having me.
Dr. Hogan, good to have you here. So tell us about the bone marrow and stem cells.
So that's a very interesting question and oftentimes causes some confusion. Essentially, when we're doing a bone marrow transplant or a stem cell transplant, the idea is to try and replace healthy cells with, or replace the diseased bone marrow with healthy cells. Sometimes we use the person's own cells. That's appropriate for certain diseases, such as multiple myeloma or lymphoma, where the cells that we collect are not usually contaminated by the underlying disease. For other diseases, such as leukemias and myelodysplastic syndromes, we have to use cells from a different person because the cells that we collect may be contaminated by the disease. So there's two different types. There's one which comes from yourself, an autologous transplant, and one which comes from somebody else, an allogeneic transplant. And within that, we can collect either from the bone marrow itself in the pelvis with a surgical procedure, or we can collect from the peripheral blood from the arm by using a machine like a dialysis machine to try and collect the cells. The one where we collect through the dialysis-like machine, called leukapheresis, is called a peripheral blood stem cell transplant. The one where we collect from the pelvis is called a bone marrow transplant. But sometimes we use the term bone marrow transplant colloquially to mean both.
Now, what do these stem cells do?
So the stem cells are kind of like the seed cells. If you have a garden and you plant seeds, these are what produce all of the plants in the garden. Similarly for us, the stem cells produce the red cells that produce hemoglobin that help us function and allow us to supply oxygen to our tissues. The white cells, which help us fight off infections, and the platelets, which help prevent us from bleeding. So they're the underlying cells that produce all of the important things that we need in our immune system and in our blood-producing system to function.
You mentioned that you're replacing diseased cells in someone's marrow with fresh, good stem cells. Do almost all of these patients have cancer, or are there other reasons why someone might need a transplant?
Yeah, that's an excellent question. The vast majority of our practice are patients that do have a form of cancer, usually a blood cancer like lymphoma, multiple myeloma, leukemia, myelodysplastic syndrome.
And by the way, explain myelodysplastic syndrome.
So myelodysplastic syndrome, the old name used to be called pre-leukemia. This is a condition of the bone marrow where the bone marrow doesn't work normally, so it can result in two problems. One is where there's failure of the production of the cells in the bone marrow, or that they can convert into a form of leukemia. So it's an abnormal bone marrow problem where you can have either failure of production or transition to acute leukemia.
How long have you been using stem cells to cure these or to solve these problems?
So this goes back, so the original bone marrow transplant was done in 1963 at Mayo. And since the late 1980s, early 1990s, we've been using more peripheral blood stem cells.
So you mentioned that the type of stem cell transplants, and by the way, I think you were going to explain to us that why you do these transplants. Cancer is the most common reason, but there are other reasons?
Yeah, in our practice, the vast majority are blood cancers, but there are other types of cancers. So for instance, germ cell tumors, which can affect the testicle, sometimes can be treated with a bone marrow transplant. And then there are other variety of diseases like immune disorders, bone marrow failure syndromes, diseases like sickle cell disease or thalassemia that can also be considered for a transplant.
And then tell us a little bit more about the source of the stem cells. You said that they could come from the patient themselves. That's one option. They could come from a donor. And then can't they also come from an umbilical cord?
Correct. So it depends again on the type of transplant. So for some people, they can come from the person themselves, and that can be either bone marrow or peripheral blood, but almost exclusively now we use peripheral blood for that indication. For getting them from a donor, we have a number of options. The most common one that we would like to use is a matched sibling or brother-sister donor. But sometimes we can use other family members. And what's become more popular recently and more effective is half-matched transplants or haploidentical transplants. And oftentimes this expands the donor pool. So in a patient that doesn't have a matched brother or sister, then we may be able to consider another family member, such as a parent in the case of a child that has a disease, or a child in the case of an adult that has the disease, as a potential donor. And with the recent technology that's allowed us to do half-matched transplants more safely, this has actually become a very significant new technology that's allowing access to a lot more transplants for patients.
So it would seem to me like if you had the opportunity, you would always use the patient as the donor, because then you don't have to worry about rejection. And so tell us again why it is you don't always do that.
Right. So I think for certain diseases, we know that a person's own stem cells can be useful. So for instance, multiple myeloma or lymphoma, frequently, because the cells we collect are not involved by the disease that we're trying to treat, then we can give high-dose chemotherapy to try and reduce or eradicate the underlying myeloma or lymphoma, and then use the stem cells as a way to just repopulate the bone marrow after the high-dose chemotherapy. In that situation, most of the effect of the transplant is relying on the high-dose chemotherapy, and the stem cells are there to repopulate the bone marrow afterwards. That's not entirely true, because there's some evidence, primarily generated at Mayo, that suggests that there may be also an immune effect by the cells that we put back in. But in an allogeneic transplant, the cells that we collect are not feasible. One, that we can't collect enough because they have an underlying bone marrow disease that doesn't allow us to collect the cells, or that they're impacted by the disease itself, and the cells we put back in would be malignant and therefore wouldn't be a very good option.
So umbilical cord, do you use that when you can't use the patient's own stem cells or bone marrow and you can't find a good match?
Absolutely. It's a possibility. Umbilical cord was very popular for a long time, especially in children, because there are some limitations with umbilical cord. One is that the size of the unit that we can take, which is, after all, a newborn baby, tends to be quite small, and therefore for most adults, a single unit is not sufficient. There was a recent very large study that had looked at half-matched versus umbilical cord blood, and there's a slight advantage in some situations for the half-matched transplant. So we are using more and more half-matched transplants, but still in the right circumstances, umbilical cord transplants are very appropriate and reasonable.
And those are not embryonic stem cells?
Absolutely not. These are healthy babies that are born that have the umbilical cord that is normally discarded after the birth, where we can collect the stem cells that are sitting in the umbilical cord that would otherwise be discarded, and we can use those for a transplant.
I always thought that again, you're holding up about 2 feet of umbilical cord, and the small amount of stem cells that can come out of that. I always thought that those were just taken to the lab and expanded out, like you could grow them. Mm-hmm. Is that? Of course, I'm not a scientist.
Well, you've actually had a very perceptive question there, because in general, we don't expand the umbilical cords, but there is newer technologies looking at ways of trying to expand umbilical cord units to try and help get better engraftment and to improve their potential. So I think maybe you should consider being a scientist and not being a radio host.
Well, are those, if you get from a child or from umbilical cord, are those stem cells healthier than if you get from an adult donor?
Not necessarily. I think they have different characteristics. They're more immature because they haven't seen a lifetime of infections and viruses that an adult would have seen. So that there's good and bad to that. On the one hand, adult stem cells might be better at able to control certain infections because they've seen them before and recognize them. But younger children are more immunologically naive, and therefore they're less likely to cause severe complications like graft versus host disease. So there's pros and cons to both, and we're just trying to pick the best choice depending on the patient's individual circumstances and on the product that we have and the availability of other options that are available to us.
So if you're unfortunate enough to get one of these cancers that we've been talking about and you can't use your own cells, if you've got an identical twin, you're golden, right?
Maybe, but maybe not.
Really?
In fact, there are some interesting things that happen there. So if we had a perfectly matched donor that was not an identical twin and an identical twin, frequently we choose the other donor because an identical twin can actually be too similar. And part of the reason why the stem cells from a donor work is that they have an immune reaction against the leukemia. And that's not really available in patients that have an identical donor. So frequently, and we've been in this situation before, where we have somebody come that has a matched sibling and an identical donor, and we end up choosing the non-identical sibling, which is a surprise to many patients and even physicians sometimes.
Absolutely. Well, our guest is the director of the bone marrow transplant program at Mayo Clinic, Dr. William Hogan. Time for a short break. When we come back, we'll talk about what it's like to have a bone marrow transplant. We'll talk about the outcomes, the success rate. We'll talk about what the future holds, and we'll tell you how you can actually become a bone marrow donor. Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
We are with the director of the bone marrow transplant program at the Mayo Clinic, Dr. William Hogan. We've learned a lot about bone marrow transplants. What are the diseases that bone marrow transplants are usually used to treat? We've talked about who could be a donor and whether or not you can actually get your own stem cells. And if none of those are an option, then umbilical cord blood might be an option. So the next thing we want to talk about is the outcomes. How successful are bone marrow transplants? I know they're more successful than they used to be, but where do we stand?
So this is very much dependent on the type of disease, the type of patient, and things are evolving on a yearly basis there. So over the last number of decades, there's been progressive incremental improvements. So really, there's not a single answer to that question. It really depends on the type of disease you have. But in general, we've been able to do transplants in much older and sicker patients because the technology has allowed us to use lower intensity chemotherapy that's improved the outcomes for many patients. We've got better approaches to treat graft versus host disease. We've got better mechanisms to determine who's at risk for getting high risk complications such as severe graft versus host disease, and we've learned how to reduce the complications such as lung injury and liver injury and many other injuries related to graft versus host disease and other transplant complications.
What is the most common complication?
So the two things that are most troublesome for transplant is relapse of the underlying disease, which unfortunately is still a problem, and we've got a lot of strategies to try and help deal with that depending on the disease.
So recurrence of the cancer.
Exactly.
Okay.
And then the other thing is graft versus host disease, and I've mentioned that a couple of times. What that is where the donor immune system starts reacting against a person's normal tissues, and this only occurs generally in the context of where the donor is somebody else rather than your own cells.
Can you get a second transplant?
So we try to avoid that. We try to give the first shot at transplant our best effort at trying to make it successful. Very occasionally, then, there is a need for a second transplant or supplementing the original transplant with additional cells from the original donor, which is kind of a variant on a second transplant called donor lymphocyte infusion.
What's it like to get a stem cell transplant?
So it can be different depending on how intense the regimen that we use is. We have, in general terms, very highly intense regimens called myeloablative. Myelo means the bone marrow, ablative means wiping it out, so that's very intense. We have reduced intensity, which uses less intense chemotherapy, and both of those ultimately will result in a complete replacement of the donor bone marrow, or the recipient bone marrow by donor bone marrow. But
so this sick bone marrow, before you give them the new cells, you want to kill everything that's in there, every cancer cell, if you can.
So it's really not practical to kill every cancer cell with chemotherapy, but yes, we try to give high doses to try and minimize it as much as possible, and then use the immune system of the donor to try and eradicate what's left behind.
And once you've done that, you're basically walking around without an immune system, which is incredibly dangerous.
Exactly. So your blood counts can be very low for a number of weeks afterwards. And so these patients do require very careful monitoring, transfusion support, antibiotic support, medicines to try and prevent complications, and that becomes a challenge. But we have a kind of system in place where not all of these patients actually need to be in the hospital during that period of time. And in fact, sometimes this can be done as an outpatient with appropriate monitoring and care.
So is it like getting a blood transfusion? You feel like $1 million right away?
I think many people that got blood transfusions may not felt like $1 million right away, but I think it does take time. And so it is a pretty challenging procedure for most patients, and it does take some time to recover, and that can be variable from a number of weeks to many years for some patients, depending on how difficult and complicated it gets.
Yeah, how long does it take for those stem cells to ramp up once they're in your system?
Yeah, depending on the type of graft, somewhere between 2 and 4 weeks is fairly typical. So for peripheral blood stem cell grafts, it tends to be faster, usually a couple of weeks. And for bone marrow-derived grafts, it's oftentimes about 3 to 4 weeks.
We're dealing with the coronavirus right now.
Right.
How do viruses, infections that become fairly widespread, how do they affect your program?
So separate from the coronavirus, we deal with infections all the time in bone marrow transplant. So what is oftentimes in the environment may not affect us normally. When our immune system goes away, it becomes a very significant challenge. So things like mold spores that are in the environment, which most of us just brush off without any difficulty with our immune systems, become a huge problem in patients that are very immunosuppressed. So we have a lot of strategies to try and minimize those risks. The coronavirus is an example of a very large problem that has arisen, and this one has been particularly problematic because it's been so quick to spread across the world. It has really impacted our ability to do transplants, but we're accommodating to that and figuring out ways to try and do transplants safely. Some of the ways it's impacted us is, one, is there a risk of the products that we collect from donors, and half our donors come from outside of the United States and Europe.
Is that right?
Mm-hmm. And so that becomes a problem when we see flights shut down and things like that, then the logistics that go along with that, because the timing is very critical. Secondly, there's always a concern that if the donor was exposed to an infection such as coronavirus, is that possible to be passed on? And we don't know fully all the details about that yet. And then, whether a person themselves, after going through the transplant, might be exposed to the virus. And that, as you know, could be a significant problem as well, because the most vulnerable patients are those that are older and have other underlying comorbidities such as leukemia and blood disorders.
How much does the usual transplant cost, and is it covered by insurance?
So the cost is, again, very, very dependent on the type of transplant. In general, autologous transplants where you get your own cells tend to be cheaper, and allogeneic transplants where you get from a donor tend to be more expensive. It's really difficult to kind of give a cost for an individual, but the question of insurance for certain leukemias, so for instance acute myeloid leukemia or acute lymphoblastic leukemia, is almost always covered by insurance. There are other situations where CMS, Medicare essentially, is looking at whether the outcomes are good enough in order to justify doing a transplant, and so they've put a provisional payment system in place. And then there are other indications where it's not indicated to do a transplant, and that's not generally covered. But for the majority of indications, it's covered by insurance.
What's the future hold? Are there other cellular therapies coming along that may improve even more patients who have these serious cancers?
Yeah, I think the future is very bright. There's a huge number of new drugs that have come along in the last couple of years that have been helping us to try and reduce the risk of relapse for many of these cancers. There's better ways of trying to identify which patients are at greater risk of complications, especially graft versus host disease. And in the area of cellular therapy, you may have heard of newer technology called CAR-T, which is chimeric antigen receptor T cells. And these are taking the T cells from a person and then re-engineering them to recognize the cancer. And this has become a very successful new technology that is very helpful in controlling certain leukemias and blood disorders such as lymphoma and myeloma, and has a lot of potential for the future.
So T cells are part of the immune system, and
exactly.
You teach them to attack the cancer.
Exactly.
We have just a few seconds left. How can a person become a donor?
So if you are interested in becoming a donor for an unrelated person, then look up Be the Match online. There's a website there that will go through the screening questions to see if you might be a good person to sign up as a donor, and they will work you through it. And in general, it's very simple. What they'll do is after you fill out the questionnaire, they'll send you a swab to get some DNA from your cheek, just like Ancestry.com, send it back, and then you can be registered as a donor.
And can pregnant women donate their baby's cord blood through Be the Match as well?
So that's a very interesting question, and it's a little more complicated. There are independent cord blood banks that can collect cord blood. What I would suggest there is if you're interested in doing this, look into it sometime before you're due to deliver, because if you leave it to the last minute, it probably won't happen.
All right, the website once again is bethematch.org. I assume you're always looking for donors.
So they would certainly be always interested, especially if you're less than 45, because that's the age group that are most requested. But if you're interested at any age, check it out and see if you might be eligible.
Is there an age limit?
Over 60 for an unrelated donor is the cutoff, but for a related donor where you need to donate to a family member, that's much more flexible and can be adjusted if needed.
All right, stem cell transplants, a life-saving therapy for many patients with some cancers. Our thanks to the director of the bone marrow transplant program at the Mayo Clinic, Dr. William Hogan.
Thank you very much for having me.
Thanks for being with us.